I said to Caitlin earlier, I'm wearing my red sweater today and I have on my Canadian Mountie socks, and so I feel rather like I'm at home today. Just a bit of a reminder before I start my webinar that there's another great webinar coming up in January from Olivia Samudis and Dr. Mandar Jog's lab, and hopefully you guys will be able to attend this great event as well. A few of my disclosures, because I have to put those up there, and we'll slide past those to kind of get into the webinar this morning. So what I'm going to focus on in my talk today with all of you, and I'm hoping just to give you a bit of an outline to speak for around 45-50 minutes or so, to leave ample time for questions at the end. So feel free to write those down. We should have lots of time to go over them. My goal today is really to direct this presentation toward some clinicians who may be in attendance, but also individuals with Parkinson's disease and their families. And we really are going to focus on this aspect of communication. So I often say that this slide could very well be me in my house with my husband, and some of this is just years of marriage when you look at each other and go, what do you mean I don't communicate very well? But in this case, we really want to try to deconstruct today the kind of multiple contributions to difficulty communicating, both from the perspective of the person who has PD, but also from the perspective of their family members, which is really at the nexus of where my research lies. I want to address the complexity of this issue and why it's not simply just a motor speech issue, and how that affects thinking about interventions and assessment for individuals who have Parkinson's disease. And then present to you some of the newer studies that have come along in this area, including some work from my own lab and colleagues of mine, and really taught you, in really the predominant kind of part of the last 2/3 of the talk will focus on practical tips and ways that we can help to mediate some of these concerns. So communication in Parkinson's disease is complicated, and these are all quotes either taken from people that I've worked with who have Parkinson's disease or from their family members. One of the things that becomes really clear from these kind of descriptions of the problems that people have is the fact that it isn't just about speech, that there are difficulties with finding the right words that people want to use. There are challenges with keeping up and staying with the pace of conversation. People with Parkinson's disease kind of frequently describe that they feel like they're getting left behind, that by the time they process what others have said, by the time they're ready to plan what they want to say, that the conversation's moved on so far that they feel like they've gotten left out. And now when they take their turn, what they have to say may no longer feel appropriate or on topic. And some of the earliest symptoms that some people with Parkinson's disease actually complain about in this quote, and kind of the lower right-hand side of your screen really reflects that, which is a woman who really didn't notice that it was her motor problems that were most disturbing to her at the beginning of her disease, but the fact that she had trouble finding words. And although Alzheimer may seem like a word that's uncommon to most of us, this person was a faculty member in the Department of Chemistry, and so it was a word that she used a lot. And she'd be in front of her class and just get stuck on being able to find a word. And so this was really the reason why I went back to do a PhD. I was a speech language pathologist. I was working with these people, and it was rather disturbing to me that a lot of the interventions that we had available were focusing more on the motor aspects and weren't really addressing communication as a whole, and yet these were the concerns that were being voiced to me by the people that I had the privilege of working with. But without a doubt, the motor aspects of communication challenges are problematic in this population and are significant. Some of the first communication changes that people might report relative to their speech are a quieter voice. That's rather common. Kind of a hoarse or rough vocal quality is often reported. Kind of a flatness of the voice, so there's not as much variability, and this is really problematic for people who sing or who sung professionally when they were diagnosed with Parkinson's disease, because they may lose the vocal range that they were used to having the flexibility of prior to the disease. And then another common complaint that often gets overlooked sometimes by us as clinicians is this notion of just fatigue from talking for long periods. And we think these are driven by changes that result from Parkinson's disease at multiple levels in the motor system. So we know that vocal control and some issues around intensity are related to kind of changes at the voice box or the laryngeal level, but also are complicated by changes at the respiratory system, or the kind of amount of breath support that you have for producing speech. And then we know that there are also concerns with kind of the clarity of speech sounds when they're produced, or people feeling like they're stumbling a little bit as they attempt to produce speech sounds. I'm going to share with you some new research that's pretty hot off the presses. So we just actually finished this analysis within the last couple of weeks. This research is done by a PhD student that I work with here at Northwestern. Her name is Jordan Maines, and we've now submitted that for publication. She's presenting it at the Motor Speech Conference in a month's time. But this is actually some work looking at how the brain changes in the context of Parkinson's disease, and what we see about those brain changes in people who have speech problems and in people with Parkinson's disease who don't have speech problems. So we looked at 89 people that were distributed between people who didn't have Parkinson's disease, people who had Parkinson's disease and did have speech problems. So this kind of what we call in this figure that's in front of you, this PDSI group, and a group of individuals with Parkinson's disease who did not have speech problems. And we were really interested in how their brains differ. And there was an interesting finding that came out of this. We saw that the parts of the brain that were losing connection to one another, and this is really important concept in Parkinson's disease, where we need to think about not just the regions of the brain that changes, but the regions of the brain that stop talking to one another as effectively or as efficiently. And in this case, we found that those who had more speech problems had focal problems on the left side of their brain, so very few changes on the right side of their brain. These problems were more focused on the left side. And we also found that there were reduced connections between kind of the subcortical structures of the brain, so those structures that we think are affected in Parkinson's disease, and a part of the brain that we call left STG, or the superior temporal gyrus. Now this becomes really important because it implies that in addition to disruptions in the connections to primary laryngeal or motor complex systems of the brain, we actually think that there are disruptions to the parts of the brain that we use to monitor our speech and plan out our speech, and to monitor for how we integrate language or the words that we want to use, the concepts that we want to express, and the ability to articulate the words that map onto those concepts or map onto those ideas. And so this research adds to about 2 other studies now in the literature that show that people with Parkinson's disease who have greater speech impairments are also having some disconnections or some reduced connectivity to regions of the brain that we use to not just produce what we want to say, but to plan out the words and the ideas that we want to express. And this becomes important as we start thinking about the connections between how we express ourselves from a motor signal, but how we're also planning what we want to say. And it adds some scientific evidence to what some of us have been saying for a long time now, which is the communication issues in Parkinson's disease are not purely limited to motor aspects of production, that there is this kind of other cognitive or other language planning process that may be also affecting how we produce speech sounds, but also how we communicate on a daily basis. And this was really remarkable because we were able to see this is not a difference just with people who don't have PD, but a true difference between people who have PD with speech problems and people who have PD who do not have speech problems. And so this, as I was saying, begins to confirm for us that the changes that we see are not just related to speech and to voice, but may also be related somewhat to hearing, may be related to cognitive behaviors such as memory, focus, and thinking, and may be related to how we conceptualize what we want to say, how we plan out the words that go with what we want to say, and how we put those words into the organization of a sentence. And this has kind of opened up the door for more research questions to begin to be asked. But we're going to explore each one of these areas in some detail and then talk about how we can treat or manage or approach improving each of these areas. And the first one I'm going to start with is Parkinson's disease and hearing loss. And so this is, again, some new research that's come out really since 2012 with 2 prominent studies that have come out in the last 2 years, showing that people with Parkinson's disease are more likely to present with hearing loss than age-matched individuals who don't have PD. This is important. So hearing loss is the 3rd most chronic health condition in people over the age of 60. We know this. As we get older, hearing loss becomes more common, but it seems to be more common that people with Parkinson's disease have hearing loss, and this may be a difference that results from the disease and is not just a function of age. The changes that we see in hearing affect both the ability to listen to tones, but also affect the ability to listen to speech sounds. And these changes were present even when the individual with Parkinson's disease had no awareness that they had a hearing loss. And the hearing loss was of a severity that would disrupt communication and conversation. And this is important from a cognition piece as well. So we know from the hearing literature and from the hearing loss literature that when you have more trouble listening, when you have to strain harder to listen, even if you're not aware that you're straining to listen or that you're having to put more work into listening, that the brain uses more resources. So the more difficulty that you have hearing, the harder you have to work at discriminating speech sounds or what people are saying, the fewer brain resources you have to dedicate to focusing or paying attention or remembering something or even speaking. This has led to a body of literature in the hearing loss world saying that we need to treat hearing loss really early so that we can restore these brain resources that are used for other processes like communicating and like remembering. It's also led to a body of research that has shown that there's an increased connection between having hearing loss and developing dementia. And there seems to be some relationship between this increased risk for hearing loss and the development of cognitive decline that exceeds what we expect for aging. And so this area of research I think we should keep an eye on. It certainly creates an advocacy for the fact that people with Parkinson's disease should have their hearing checked, and probably early on in the disease. Certainly we know that treating hearing loss can improve communication, and in this case we could also make an argument that perhaps addressing hearing loss early might have an impact on cognition. Another interesting body of research that we've just kind of finished with collaborators, including myself and Dr. Ken McRae at the University of Western Ontario, was a study that we looked at to see to what degree the motor impairments in Parkinson's disease actually affect how we retrieve words and how we use language. And this is important because there's a few theories out there that say that when we're thinking about words that involve actions, and also words that don't involve actions, but let's focus on verbs or action words at this juncture, that when we are thinking about action language, when we're using words that convey action, we actually activate regions of our brain and even muscle groups that we use in those behaviors. So if you're thinking about playing soccer or saying the word soccer or saying I'm going to kick the soccer ball, you actually activate muscle movements, even if you can't see yourself actually doing that activity, but the muscle activity and the regions of your brain that you would use when using your arms and legs to play soccer actually begin to become active. And this led us down the path of thinking, well, gosh, if this is the case, to what degree do we actually see some of these motor impairments affect the ability to use certain words in Parkinson's disease? And so we did this study where people read words on a screen, and they had to decide whether it was an action word or if it was not an action word. And what we know is that the quickness with which people are able to do this, if you hit really quickly that you know it's an action word, that means your brain is processing that information faster. And if you're slower to do that, it means that your brain is having more difficulty activating these regions that would be used to process these words. And we just recently published these findings about a month ago. It was really interesting that people with Parkinson's disease who had more upper limb involvement, so more involvement of their arms and hands, were slower to process words that were using those limb groups, so things like pinch, and were faster for words like kick, using the limbs that they were less affected in. Likewise, when we looked at patients who had more lower limb or limb involvement, they were a little bit faster to process words using their upper body and slower processing words using their lower body. So in addition to hearing that affects communication, we're beginning to see this direct relationship between some of the motor impairments that we see in Parkinson's disease and how that affects actually processing certain words in our language. And my work looks at that kind of fine-grained experiment level, but we're also really interested in how people communicate in real-life context. And to this end, we do a couple of different things in research. Some of this work has been funded by the Canadian Institutes of Health Research, some of it by Parkinson Society Canada, and there may even be some of you on the webinar today who participated in some of these studies with us. But we do two things. We might have people describe a picture, and that picture description lets us get a sample of their language that we can analyze. And we're looking for errors that tell us that someone's having difficulty retrieving their words and putting words into sentences and kind of conveying their ideas. The second thing that we do in our research paradigms is we actually go into people's homes and we record them having conversations. And we do this using what's called a mealtime conversation analysis protocol, which is well reported in kind of this research world. And we look at how things like Parkinson's disease or interactions with conversation partners actually change aspects of communicating. So pausing, or the need to repair or start again what you want to say, speech errors that you might make, or word choice errors that you make. And in the conversation realm, we look at things like turn taking and pausing and miscommunication of messages. And one of the things that we have found is that we can do two things really well just using these data. We can actually identify who has Parkinson's disease and who does not. But the other thing we can do is identify who is at risk of developing cognitive impairment in Parkinson's disease, or those people who may be at greater risk of developing dementia. And we're continuing to refine what we call this biomarker of cognitive impairment in PD. It becomes really important because currently, in order for us to advance treatments and interventions for dementia and Parkinson's disease, we need to find it at its earliest point. And one of the things we don't do very well right now, or that our tests don't do very well, is it identifies when people with Parkinson's disease have dementia, but often at a time in the disease when it's too late for us to really modulate the brain systems or the neural systems to slow down or reduce the risk of developing dementia. And what we find is that these spoken language markers, these things that we see in everyday communication patterns, might actually be a more sensitive marker of that earlier on in the disease. And so if we can refine these, then we can perhaps use these types of data to target people who are at risk earlier, helping us to develop treatments. The other thing it lets us do is to look at what are the types of conversation breakdowns that people have. If you're living with someone who has Parkinson's disease, or if you are someone with Parkinson's disease, you definitely know that in the context of conversation, there's lots of these huhs, whats, I didn't get you, what did you say, can you say that again? And we define these as breakdowns. Any problem where the message that you intend to send or that you need to receive doesn't get through. And for the longest time, we thought that all of these breakdowns that we see in conversations were the result of just speech clarity or voice volume issues, because we often will look at someone and say, I didn't get that, and the interpretation is that someone didn't get it because their voice wasn't loud enough or their speech wasn't clear enough. And what we actually found out when we looked at this was that that is true. Sometimes that does happen. But roughly 2/3 of the time when these conversation breakdowns occur, that they don't really occur because of voice volume issues. They don't really occur because of speech clarity issues. They occur for reasons that we think are more related to cognitive changes and to language-related changes. So these long pauses in conversation that are not linked to, and the way we do these methodologies, we're able to pull this apart, that aren't linked to motor issues, that are linked to how much time it's taking for the person with PD to potentially process information. We also see that the use of incorrect or ambiguous words makes it hard for conversation partners to follow what's being said. And this seems to lead to a pattern in conversation partners of people with Parkinson's disease, family members, where they just tend to abandon communication attempts rather than jumping in and trying to repair them. And this has really led us down the path of thinking about, in addition to some of the interventions that we do for increasing voice intensity and speech clarity, how are we counseling and working with family members and with what we call the conversation dyad, the person who has Parkinson's disease and their family members, to make them better communicators in the context of Parkinson's disease? Conversation patterns change over a lifetime, especially if you've been married for a long time. Conversation patterns differ. But what we're seeing here are not really the nuances of being married for a long time or being in a relationship for a long time. They are the nuances that are the result of PD, and therefore are things that we should be able to treat or help to counsel and work with families to respond to and to get around to improve communication. And so what have we learned? And I present this to you so that we can then jump into kind of some of the solutions to this. But we've learned that communication challenges in PD are so much broader than speech and voice impairments. They just are. And we've learned that we need to think about assessment and interventions in ways that address comprehension or our communication more comprehensively, that don't just address speech and voice impairments. And we need to do this in order that we help people to maintain their social relationships. We need to do this so that we can better understand. I was just on a phone call this morning with a colleague of mine at Purdue University who does a lot of research in Parkinson's disease, and I'll be talking about some of her research here in just a few slides. But we were talking about this fascination of this interplay between the motor impairments that people have, the cognition, the very subtle cognitive impairments that we see early on in the disease, both in the context of dementia but not in the context of dementia, and these very small changes in language that have big impacts on how we communicate in our everyday lives. And understanding the relationships among all three of those things is really important for us to understand Parkinson's disease in a way that should advance what we understand about brain changes in this disease beyond just the motor symptoms of tremor or slowness or rigidity. And then thinking about how we use technology and our changes in technology to be able to develop state-of-the-art devices and interventions to help support people with Parkinson's disease. And to this end, we're living at a really interesting time. So our conceptualization of communication impairments in PD is really starting to change. The curve is bending in terms of how clinicians and researchers are seeing this problem. And there really is, for those of you who have Parkinson's disease, in 5 years' time, I'll be giving you a very different talk, because there's a large push in research right now to try to really advance interventions for this group of individuals, and we haven't seen that in a long time. For a long time, we've had very few interventions for Parkinson's disease. They've worked well, but they haven't worked well for everybody. And so this is really kind of this new dawning of Parkinson's disease research in speech and in communication issues. And I look forward to kind of introducing you to some of this now and then revisiting you hopefully in a couple of years with even more advances in this direction. So it's this kind of point, well, if I don't do anything, something magical is just going to happen, I'll get better, right? And no, that's not the case. We actually know that these changes, whether they're mediated by cognitive changes or language changes or speech changes, actually require intervention. And to this end, this word dysarthria kind of captures at least the motor speech changes in Parkinson's disease. We can do this in kind of one of four ways. We can actually look at building skills. We can look at rebuilding the respiratory or the speech or the laryngeal or the kind of functions that support speech production, and we have treatments for that. We can look at using cues in the same way that people use cueing for gait and gait rhythm. Those cues can either be external with some of the technology devices that have been developed, or they can be internal cues, you thinking about modifying your voice intensity or thinking about modifying the amount of effort you put into producing speech sounds. Lee Silverman voice treatment, which is what the LSVT stands for, and I'll cover that in a slide here in just a minute, also focuses on recalibrating effort and loudness. So one of the issues that we see in Parkinson's disease is that people will often feel that they're being loud enough to be heard and to be understood, but they're actually not being loud enough. Their perception of what is loud enough changes in the context of this disease. And so part of what this therapy does is to try to recalibrate that notion of effort and loudness. And then there's components of compensatory compensations as well. But I want to share with you, for years we've kind of said, well, things like LSVT work and exercise programs for voice work, but now we actually have some lab science that says they do work. And there's good reason now for thinking about treating voice and speech and communication problems in Parkinson's disease and treating them early. So the slide I have in front of you is some work from Michelle Ciucci's group at the University of Wisconsin. And what she's been looking at, yes, is training animals that have a Parkinson's-like condition, but training them to do voice exercises. And she's been trying to look at the real kind of effect in a very scientific experiment way where we remove the biases of people thinking about getting better and placebo effects. We try to remove that from these data by doing this with animals and not humans. But the pattern that you see in front of you that's labeled A is kind of a normal voice pattern. We don't have to get into the details. This is particularly measuring frequency of the voice, but we'll just kind of leave it and say that's a normal voice pattern. Pattern B is what happens when people have Parkinson's disease, or in this case when the animal model has Parkinson's disease. And image C is what happens after about a 6-week vocal training program, right? Equivalent to what we think about doing in humans, around 4 to 6 weeks worth of work in human equivalent. And you can see that the pattern there in picture C looks a whole lot more like picture A than picture B does. And this tells us that we can take the animal who's been affected, whose voice system has been affected by Parkinson's disease or Parkinson's-like pathologies, and actually make them look a little bit more like normals through the use of exercise programs. These are intensive exercise programs, but very similar to what we're doing in humans. So this now gives us that really hard science proof that intense vocal exercises work. There's some extra work, extra research by, and some reviews done by Russell's and colleagues from around 2010 that actually show that doing these types of treatment early on in the disease actually may slow down the progression of voice issues. One of the challenges, and we'll talk about this a little bit down the road, is that we often don't refer people for voice or communication interventions until the problems are so severe that they're drastically affecting their quality of life. And this research would say, yeah, maybe that's not the right answer. Maybe we need to be referring people earlier on. Maybe we as speech-language pathologists need to be advocating early on for doing these interventions before people are, significantly symptomatic, because it may actually get us gain and traction for reducing or slowing the progression of voice changes down the road. And so we're getting some of this from these animal studies, and this is something to keep an eye on as Michelle continues this work. I'm going to introduce you to a device. Some of you have probably seen me present this before, but this research kind of continues to progress and continues to gain traction, and so I want to reintroduce it to you. This is one of the newer interventions that we have available in Parkinson's disease. It is available in Canada as well as being available in the US. And I know there are efforts being made for funding it through the Assisted Devices Program in Canada, and I know that there is increasing insurance coverage for it on the US side, and so I suspect in 5 years' time when I revisit you, we'll be talking about this device as being a routinely covered device because the evidence is just growing and growing and growing in its favor, that it's effective and it's cost effective. But this is a device called the SpeechFi, developed by my colleague Jessica Huber at Purdue. That's the person that I was speaking with this morning. It looks like a hearing aid, and it fits in the ear. You wear it on one side. It's not occlusive, meaning that it doesn't block your ear. You're still able to hear around it. But it operates on a principle that we call the Lombard effect. And this is one's natural tendency to increase your voice volume in a high noise environment. So meaning that if you're in a restaurant and there's lots of noise in the background, you're going to naturally tend to push your voice to a loudness level that is above the background noise so that the partner that you're eating with or having a conversation with is able to hear you. And what we know that in Parkinson's disease, this is pretty well preserved. People with Parkinson's disease may not can get their voice as loud as someone who doesn't have Parkinson's disease, but this natural reflex or natural tendency to want to increase voice intensity is still roughly preserved in PD, allowing us to optimize this effect to get people to elevate their voice without them really having to think about elevating their voice, because this just happens on an automatic or kind of reflexive basis. And so the Speech 5 is a device that does that. It plays this kind of cocktail noise or background noise through the this kind of hearing aid or hearing aid casing looking device. And the way it works is that with a speech-language pathologist, there's kind of this baseline setting. A speech-language pathologist goes in and changes the setting to just get a slight increase in voice intensity, but one that's important, about 3 to 5 decibels. That doesn't sound like very much, but if you are someone whose speech is quiet, it actually can go quite a ways in terms of getting the voice to increase in loudness. Then you go home and wear the device 2 to 8 hours a day, 7 days a week, and you do kind of this what we call therapeutic reading, where people sit and read for 30 minutes a day, 5 days a week, as a way of kind of practicing your voice with the device on. And then you go back and see a speech-language pathologist every 2 weeks, and they adjust the setting until you get a sufficient amount of voice loudness gain that you feel comfortable with that and is meeting your needs. Normally kind of around the 8 to 10 decibel region, although you can set it a little bit higher than that. But this actually is an exercise program. So this is a device that does a couple of things. When you're wearing it, it certainly helps for your voice to get louder. But even when you take the device off, and in this graph what you're looking at is the green, or the green is actually when people are wearing the device, the purple is when people are not wearing the device. And so after 8 weeks of using this device, people actually continue to have higher voice volumes off of the device than they did at baseline off of the device. And even if we take the device completely away and we measure people's voice loudness, it maintains a higher voice loudness or voice intensity than they did at baseline without the device. People are always a little bit better with the device on, there's no doubt, but this is intended as an exercise or as a treatment because when you're working to use your voice in a louder way throughout practice exercises in the day while you're wearing this device, which will immediately kind of make your voice louder, you're actually strengthening the muscles underlying your voice. So you're strengthening your laryngeal system, you're strengthening your respiratory system, you're strengthening the muscles of your mouth and your jaw that you're using for producing speech sounds. And you're doing so without having to think about being loud or focusing on being loud. So this is a device that is catching some significant traction, particularly for people who have more cognitive impairments, for whom traditional interventions of thinking about being loud or having to focus on being loud is really hard for them to do. And so I would encourage you to kind of keep an eye on this device, but also to raise your awareness that it's not really an experimental device in that it is in clinical use currently. And 3 years ago when I talked to people, it was just coming in and I couldn't say it was in clinical use everywhere, and now 3 years later I can say this is where science has advanced and we have a new clinical treatment for Parkinson's disease. We look at it in comparison to something like Lee Silverman voice treatment, which has been around for a long, long time. We have more than 20 years of research on this high-intensity exercise program, and we know that it works. One of the challenges with LSVT is the amount of time requirement, and this is where it differs from the Speech 5 device, where you can literally see you are doing your exercises at home every day, reading and just really doing what you do on a communication daily basis. But you only have to see the speech therapist, once every 2 weeks. With this device, the LSVT, or with this therapy, the LSVT intervention, it requires 4 days a week for 4 weeks. So right away, there may be different people who, are kind of attracted to one intervention versus the other, just because the amount of time commitment that is available for attending therapy sessions or the distance that you live from a speech-language pathologist. It's respiratory and laryngeal system focused, meaning that this therapy is really focused not so much on speech clarity, but on making one's voice louder. It is high intensity exercises, so those of you who've done this intervention will remember your ahs and practicing of functional phrases. But this is basically going to therapy and really doing these, kind of speech exercises and voice exercises. Upwards of even 200 repetitions a session in an ideal LSVT session, and then working to generalize that outside of the clinic. This high-intensity program, consistent with the animal model work that I taught you about from the University of Wisconsin, works. It works not only in terms of behavioral changes, but also works in terms of brain-related changes. We know that post-LSVT, the brain is producing motor speech movements in a way that looks more normal than prior to treatment. And a small study, but a few studies that have looked at that. LSVT, though, as I said, one of the challenges with it is the intensity of it. Not everybody can do that amount of intensity. So they have tried to modify how it could be delivered, and it seems like the intervention can be really just almost as effective if it's done 2 days a week for 8 weeks. New technology has made it available for people to actually receive this intervention through a telehealth module and through online interventions. So no longer do people have to go into a speech-language pathologist. This can be done with specialty certification from the Lee Silverman Voice Treatment Foundation. Can actually be done through a telehealth module, through a computer. And so even though LSVT has been around for a long time, we know that it's effective for the majority of people. There's still a subgroup of people who don't respond to this intervention. But it is available now, in the advances of our intervention now, is that it can be done through telehealth and online mechanisms, and really thought to be just as effective as if it's done one-on-one and face-to-face. So this is now our challenge as a health system, and challenge as speech-language pathologists, to think about how we get these treatments to people that we now know can be delivered efficaciously through other mechanisms, in order to make sure that all people with Parkinson's disease have access to early treatment interventions for these voice and speech changes. So outside of those, are really, there are kind of other speech exercises that have been raised, and people often will ask me about things like music and choral singing therapies and whatnot. Still, at the end of the day, and I've looked into this research a lot, notwithstanding the fact that individuals feel like they're getting better, and they probably are changing, their voice probably is changing. At the end of the day, when we look at kind of gold standard research methods of ways of proving that an intervention is effective, really about the only two interventions that we have that show strong effectiveness are the Lee Silverman voice treatment that I just covered, and the Speech 5. Outside of that, for true speech and voice changes in Parkinson's disease, those are the ones that have the most evidence and are thought to be most efficacious. But another problem that happens in Parkinson's disease is this kind of change in rate. People can get very fast and almost develop these stuttering-like behaviors. And to that end, people played with a lot of these pacing therapies. So kind of tapping your finger from a low-tech perspective, tapping your finger on different circles to pace yourself, using technology and a smartphone app, practicing reducing your rate or pacing your rate, using kind of an app-based intervention to help you go slower, even using old-fashioned metronomes people have done. Some newer technology are these things that, again, look kind of like hearing aids, but are actually used to deliver an altered auditory feedback. Something that we call, either pitch-shifted feedback or delayed auditory feedback, so playing your own voice back to you at a slight delay, a treatment that's been used for years in the stuttering research as a way of kind of changing how you process feedback about your own voice production, and consequently resulting in a slower speech rate. At the end of the day, this is an area where we do definitely need more research. So a study done in 2010 showed that these more kind of traditional speech rate measures or speech rate therapies didn't do a lot. And while there's some unpublished research that shows that devices like the Speech Easy and do change rate and result in increased communication, in large studies, they just simply haven't been done, so we don't have enough evidence. Voice amplifiers are out there. They're no one's favorite, but they are out there as a compensatory, and we have some lovely research coming from Monica Andrita, who's actually at the University of Western Ontario, that shows us kind of which of these voice amplifiers work best for people. And I know that Scott Adams and others in the Southwest Ontario region continue to kind of look at things like FM systems as alternatives and much more user-friendly devices for voice amplifiers. But these are devices for when, you know, nothing else has worked, and or people don't have the resources to commit to other types of interventions that simply are basically a microphone and a speaker that help to amplify voice. One of the challenges with them is if someone's voice is not clear, it's simply going to amplify a not clear voice. It doesn't do anything to change the speech mechanism per se. And then from my own research, one of the things that we're really interested in is kind of looking at communication strategies. And we look at this as a way of kind of thinking about minimizing resources, optimizing strengths, and helping to rebalance the conversation burden between people with Parkinson's disease and their partners, that whole notion of these conversation breakdowns. And thinking about these types of interventions as being both standalone interventions, but also things that could be done in adjunct to other speech and voice therapies. And so we have 2 studies right now where we're looking at this and have actually developed a treatment program for people with Parkinson's disease to look at helping to boost traditional intervention effectiveness by adding in this conversation training or conversation kind of coaching approach. And these are some of the strategies that we have found to be particularly helpful in people with Parkinson's disease, including allowing more time, teaching care partners to verify that a message was understood before they move forward, and also teaching people with Parkinson's to do that, and making sure that the person with Parkinson's disease and their conversation partners work together to help prepare for things like topic changes or to create room in the conversation. And those of you who are interested in this, you'll have my contact information afterwards. I'm happy to provide a bit more information about the studies and the treatments that we've designed in this area. I want to touch briefly on cognitive training because I get a lot of questions about this on a weekly basis, which is, I love my X, Y, and Z computer game program that I play on my phone, and I know it's making me smarter or making my memory better, or making my attention better. And we get a lot of speech language pathologists and occupational therapists get a lot of questions about using computer-based brain training programs as part of rehabilitation. So I just wanted to touch briefly on at least some recent research in this area. So when we look at research, we think about things like meta-analyses, just to explain to you what those are. So that's basically when someone takes all the available research and they evaluate the quality of that research, and then they statistically analyze all those studies as if they were one single study. So we get more power out of showing or evaluating the effect of an intervention by combining research that has been done by several labs or several other people. And this is a study that was published in Neurology, so it was done very well in kind of this meta-analysis approach. And one of the things that we're looking for here is the fact that anything that kind of is to the right of 0, when we see our black bars and our red kind of shape there that is to the right of 0, that tells us that we think an intervention is effective. And so this particular study was looking at these kind of cognitive brain training programs and looked at them, both those that were done by computers and those that were done just pen and paper tasks. And overall, there does seem to be this kind of positive effect that people do change on individual cognitive domains when they play these games or they do these types of cognitive training activities. Where we continue to fall short in this research is the fact that while we do see changes on test measures of memory and test measures of attention and test measures of focus, we don't necessarily see changes in everyday activities. And that just means we need to do more research in this area, but it seems like you're getting better, people get better at doing these tasks, they get better at playing the games, they get better in some of our test measures, but they're not necessarily showing great gains in kind of things like driving or translating that into other activities that are highly cognitively demanding. Exercise is one, and we know that exercise helps. and those of you who have Parkinson's disease, if you haven't heard the message by now, exercise, 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 it's a good thing. And I know at least here on the clinics that I work with in the Chicago area, I have one physician here who actually prescribes exercise on a physician pad. He thinks it's that important toward helping people with Parkinson's disease to live high quality lives. But from the perspective that we think about, there is actually a couple of studies that have shown that exercise actually helps to improve language, it helps to improve cognition, it helps to reduce the risk of cognitive decline, and reduces the risk of caregiver burden. So in addition to whatever else that you're doing to think about supporting communication and supporting conversation, exercise, like with your physical health and physical mobility concerns, is a component of that improvement as well. Touch a little bit on some of the apps that are out there, and again, what I'm trying to do is give you kind of a broad swath of the questions that I get or the things that people frequently ask me about in terms of treatment and interventions in PD, and then I'm happy to kind of explore any of these further in our question time or even through emails later on. But these are apps that are currently available and some that I can certainly support. This is one from the European Foundation for Health and Exercise. I like this app because it comes in 4 different languages. It actually helps you to track some of your Parkinson's symptoms. It has a metronome built in to support gait and walking, and it has a variety of exercises and exercise videos. So this is actually a PD kind of officially Parkinson's Disease Foundation supported app. It runs anywhere from kind of $3.99 to $4.99 depending on where you are. So it's a reasonably priced application that people with Parkinson's disease can use, and it comes in both an iOS application and an Android application. It's not specific to speech, but it has a lot of really great exercise ideas and activities. And since now I'm saying exercise is part of cognition and that's part of communication, it seemed relevant to present here. This is a great app for clinicians, so there's clinicians in the audience, so this is a really nice app to use. It really gives you a guideline for everything you need to know about managing PD. It is largely directed toward physicians and nurses, but it can be quite helpful for rehabilitation professionals as well, and it's a free app. And then lastly, this is a free application from the Northwest Parkinson's Foundation, which is truly kind of a speech practice app. It will let you record your speech, play it back. It gives you kind of a meter, which you can see at the top, for keeping your voice at a consistent level. This is an iPad mediated app, so you need an iPad to use it. It is free. Like with any of these things, I always suggest using it with the guidance of a speech-language pathologist, so he or she can help guide you in the right exercises that you may want to be doing and monitor you for any kind of to help you develop healthy habits in your practice and not necessarily develop habits that may be harmful for your voice. So hopefully what you've picked up today is that communication is complex. Speech-language pathologists and other healthcare professionals can certainly help. And so the question is, how frequently do we refer? And I want to raise this because I think I'm always in favor of trying to inform people for advocacy for increasing services for those who have Parkinson's disease and their families. And this was a study that I did in 2016 that looked at 20 Parkinson Foundation Centers of Excellence around the world. So this covers 4 different countries, including a couple of sites in Canada and several here in the US, the Netherlands, and Israel. And one of the things we were interested in, if we say that referral to rehabilitation services are important, and we do, if we say that exercise is important and speech-language pathology services are important, and we do, and how often are we actually referring people for those? So this was a study that showed in the 20 Parkinson's Foundation Centers of Excellence, people were referred for rehabilitation services only about 30% of the time. Now, one of the easy explanations for this is, well, these people don't have resources, right? Finding people who work with Parkinson's disease is really hard to do, especially in the allied health or in the rehabilitation world. But these are all centers who, by their definition, have access to rehabilitation care. So they have access to speech-language pathologists, physical therapists, occupational therapists. That's part of why they're a center of excellence. And even in those environments, they're only referring about 30% of the time. The shocking data for me is if 90% of people with Parkinson's disease have some type of speech and communication impairment, and that's what the data tell us, routinely, even in the middle stages of the disease, only about 5% of people are being referred for speech-language pathology services. This was a call to action on my part when I was doing this work, and I hope it will be for some of you as well. One of the things we know that triggers referrals, not just to speech-language pathology, but to all of the rehabilitation services, are things like hospitalization, falls, older age, and complex medical issues, which tells us that we're referring in reaction to problems. We're not referring to prevent problems. I presented a lot of data to you today that I hope says to you that early intervention matters. And early intervention, even from a communications and speech perspective, matters. And we certainly know from a physiotherapy standpoint and an exercise standpoint that earlier we start these programs, the better outcomes we see in people with Parkinson's disease. And so this more reactive referral pattern versus a proactive referral pattern is somewhat problematic, and certainly a place that we need to change in our care of individuals. And I say that because the earlier we refer people, the more we can do to help actually get normalized speech. The more we can depend on our interventions to help to slow down the decline of speech change, but also to get people into the system so we can provide education and help support communication from a broader standpoint and not just the speech and voice issues. So I'll kind of seal us up with a couple of take-home points here, and then you'll have these slides. So this notion of early intervention matters. Please continue to exercise because it's going to help with cognition and it's going to help with communication. Hearing and vision absolutely matter, and in this case people with Parkinson's disease may be more likely to have hearing loss and need to have extra diligence for assessment. And then we need to kind of be expanding how we think about some of our communication therapies to include both strategy training and maybe some aspects of these cognitive training aspects. And then lastly, just a huge thank you and a bit of an acknowledgement of my lab here at Northwestern, but always knowing that I'm never too far from home, given that I still keep my affiliation with Western, and I'm very grateful that all of you were able to attend today. So thanks very much. And Caitlin, I will pass it back over to you.